Symptom management at end of life. Objectives. Review 5 principles of symptom management. Discuss the assessment and nursing interventions for pain, dyspnea, anxiety, agitated delirium, nausea and vomiting, and secretions.
Principles of symptom management. Veterans with chronic illnesses may experience uncomfortable signs and symptoms at end of life. Often curative treatments, except those that relieve symptoms, are discontinued. The focus shifts from cure to comfort. Management of end-of-life symptoms can be challenging. Often symptoms appear in clusters, requiring modifications to the plan of care, evaluation and management of other symptoms as they arise. Standard medications for veterans on the Comfort Care Unit include morphine sulfate, lorazepam, haloperidol, atropine ophthalmic drops, hyoscyamine, prochlorperazine, and ondansetron.
The goal of pain management is to stay ahead of pain and administer pain medications frequently if necessary. Pain is the most common symptom of terminal illness and the most feared. Staying ahead of pain through medication administration is better than trying to catch up to pain already being felt. Don't focus on delivering the last dose of morphine. Focus on relieving pain and suffering instead. Veterans' self-reporting pain or discomfort is the only subjective assessment for pain management. For the objective assessment for pain management, is the veteran grimacing, frowning, or bracing a part of their body? Is the veteran sweating or moaning? Has the veteran's breathing become more rapid? Nursing interventions of pain management include administering morphine. A common hospice dose is 5 to 10 milligrams sublingually every hour as needed. Morphine is usually supplied as a liquid suspension at 20 milligrams per milliliter. Evaluate effectiveness of pain relief measures to ensure the veteran is on the appropriate regimen. Provide a peaceful environment with dimmed lights and minimal stimulation. Here is an example of what oral morphine would look like in a syringe. Pictured is simulated dosages of 20 milligrams per milliliter liquid suspension.
This is what the 5 milligram dosage of a 20 milligram per milliliter liquid suspension would look like. 5 milligrams is equivalent to 0.25 milliliters of morphine. This is the simulated 10 milligram dosage. 10 milligrams is the equivalent to 0.5 mLs. Here we see the 15 milligram simulated dosage of morphine. 15 milligrams is equivalent to 0.75 milliliters. This is what the 20 milligram dose would look like. 20 milligrams is equivalent to 1 milliliter.
Dyspnea management. The goal is to decrease feelings of shortness of breath. Shortness of breath is a subjective symptom. It can be aggravated by other underlying illnesses. Feelings of fear or anxiety can result if the veteran thinks they are choking or suffocating. For the subjective assessment, is the veteran describing feelings of shortness of breath or suffocation? Did the veteran request a fan or express a need for circulating air? For the objective assessment, you want to see if there is any difficulty clearing secretions. Are they using accessory muscles when breathing? And do they have an increased respiratory rate? Nursing interventions for dyspnea. You want to administer morphine. The common hospice dose is 5 to 10 milligrams sublingually every hour as needed. It is usually supplied as a liquid suspension at 20 milligrams per milliliter. It's important to remember that morphine is used to manage dyspnea as well as pain symptoms. You should also elevate the head of the bed or roll the veteran to the side. You should teach and encourage pursed-lipped breathing. Provide the veteran with a fan for air circulation. Check the medication administration record for other medications that might help. Look for bronchodilators, diuretics, or benzodiazepines. The goal for anxiety management is to reduce feelings of anxiety associated with worry, uncontrolled pain, or fear of death. Anxiety is often confused with agitated delirium. Does this veteran have spiritual distress or concerns about being too close to death? Are there too many people in the room? Is the environment comfortable? Anxiety can be a product of constipation. For the subjective assessment, is the veteran describing feeling on edge? Does the veteran report dizziness, feeling faint or shaky? Is the veteran reporting any unusual numbness or tingling? For your objective assessment, you're going to be looking at increased heart rate, increased or labored respirations, and sweating. The nursing interventions for anxiety include administering lorazepam, also known as Ativan or Intensol, The common hospice dose is 0.5 to 2 milligrams sublingually every 2 to 6 hours as needed. It's usually supplied as a liquid suspension at 2 milligrams per milliliter. If it is supplied as a tablet, it can be crushed and administered with food. We do not want to restrain the veteran. You should try to provide a soothing environment. Do this with soothing music, a calm voice, or dim lighting. Assess the veteran preference for people in the room.
Our goal in the management of agitated delirium is to provide comfort and safety as the veteran experiences hyperactive delirium. Agitated delirium can be confused with depression, psychosis, anger, or anxiety. The underlying disease process may contribute to delirium. You might ask, is the veteran experiencing withdrawal from opioids or corticosteroids? Agitated delirium can be caused by fever, urinary retention, constipation, pain, or anxiety. For subjective assessment, has the veteran reported changes in sleep patterns? Does the veteran admit to not knowing where or who they are? Is the veteran describing a feeling of euphoria? You might assess the patient and find that they are experiencing hallucinations. They've had a change in mental status, an increase in confusion, disorientation, or difficulty understanding speech. The veteran may have rapid or unpredictable mood or personality changes. Our nursing interventions for the management of agitated delirium include the administration of haloperidol. The common hospice dose is 0.5 milligrams sublingually every 4 hours as needed or indicated. It's usually supplied as a liquid suspension at 2 milligrams per milliliter. Stay close to the veteran if possible. Provide reassurance with calm speech and soft touch. Keep the veteran safe and protect them from injury until they are calmed by Haldol. Our goal is to manage the symptoms of nausea and vomiting. Some general considerations with regard to the management of nausea and vomiting include that nausea and vomiting may be caused by complications of the disease process. Some medications may cause or exacerbate nausea and vomiting. Constipation, impaction, and bowel obstruction can cause decreased appetite, nausea, and vomiting. When assessing the veteran, do they describe feelings of nausea or indicate instances of vomiting? Does the veteran describe feelings of abdominal pain, fullness, acid reflux, flatulence, or hiccups? Is the veteran actively vomiting? Does the veteran grimace, guard, or gesture to their abdomen? Does the veteran have a distended or rigid abdomen? Does the veteran take medications associated with nausea and vomiting? Our nursing interventions for the management of nausea and vomiting include the administration of chlorchloropyrazine or compazine. The usual hospice dose is 10 milligrams PO every 6 hours, or 25 milligrams rectally every 12 hours. Another option is ondansetron, 4 to 8 milligram tablets administered sublingually every 6 to 8 hours. Nursing staff wants to assess for other possible causes of nausea and vomiting. You want to review the veteran's medication administration record for medications that may cause nausea or vomiting. And if that's the case, advocate for changes to the veteran's medication regimen if they are causing side effects. Advocate for alternative medication options for the management of nausea and vomiting. Collaborate with hospice nurse, physician, or other hospice organizations to satisfy this need. Secretions are often associated with a prior diagnosis of dysphagia, stroke, ALS, congestive heart failure, bronchiectasis, chronic bronchitis, or gastroesophageal reflux disease. All veterans, regardless of diagnoses, may experience secretions at end of life. Does the veteran describe difficulty breathing? Does the veteran describe difficulty clearing his or her throat? Does the veteran describe a choking sensation? On assessment, you hear audible, noisy, or rattling breathing. You observe the pooling of secretions in the back of the throat. The veteran is drooling. Secretions are pooling in the corner of their mouth or on the pillow or bed linens. Does the veteran appear to be choking? Our nursing interventions for the management of secretions is to administer atropine ophthalmic drops. The common dose is 1 to 2 drops sublingually every 2 hours as needed or indicated. Please be aware that these ophthalmic drops are in fact administered sublingually. Early and frequent administration may be required to manage this symptom. Do not suction as it can cause discomfort, distress, agitation, and increased secretion production. Advocate for alternative medication options for secretion management by collaborating with hospice nurse, physician, or the organizations themselves. To manage secretions, Attempt to position the veteran in a way such that they are side-lying and their mouth is lower than their throat.
You should contact the hospice agency or physician if you have questions about an order, if you feel the order for pain management needs adjustment. And just keep in mind that hospice care is available for consult 24 hours a day, 7 days a week. The phone number for each hospice agency can be found at the nurse's station or in the patient chart.